Assalamu alaikum and very good evening to everybody. I would like to convey my heartiest gratitude to everyone for joining us to this wonderful evening. Despite your busy schedules, it is my pleasure to have such wonderful and very talented cardiologists with us right today. We have two talented panelists, Professor Sabina Hasim is working as interventional cardiologist and professor of cardiology in our prime institute, that is National Institute of Cardiovascular Disease and Hospital. And another young dynamic interventional cardiologist, Dr. Nur Alam, is working as associate professor of cardiology in NICB, same institute. And we have four talented speakers today. Dr. Muhammad Asaduzzaman is working in our institute, that is National Heart Hospital Research Institute as registrar of cardiology. And again, another talented cardiologist, that is Dr. Farad Jamal, assistant professor of cardiology and consultant of cardiology in our institute. And Dr. Nazmul Laila, she is also working as registrar in our hospital. And last of all, our beloved and renowned professor of cardiology, that is Professor Dr. Nazir Ahmed sir. He is working as professor of cardiology in our hospital. First of all, I'd like to have a request to our first speaker, without killing our time, to have delivered this topic on classification of cardiomyopathy, especially dilated cardiomyopathy. Dr. Asad, please share your slide with us.
Respected coordinator, expert panelist, and the audience. Assalamu alaikum. I am Dr. Asaduzzaman, and welcome all to the National Heart Foundation Cardiac Course presentation. And today's topic is cardiomyopathy. My part is to define and classify the cardiomyopathy. The definition of classification of cardiomyopathy have evolved considerably in recent years due to the development of genetics and imaging techniques. And what American Heart Association defined a heterogeneous group of disease of the myocardium associated with mechanical and or electrical dysfunction, which usually exhibit inappropriate ventricular hypertrophy or dilatation due to a variety of etiologies that frequently are genetic. Cardiomyopathies are either confined to the heart or a part of generalized systemic disorder, often leading to the cardiovascular death or progressive heart failure related disability. World Heart Federation also defined cardiomyopathy as a disorder characterized by morphologically and functionally abnormal myocardium in the absence of any other diseases that is sufficient by itself to cause the observed phenotype. Now the classification. American Heart Association categorized cardiomyopathy as primary or secondary. In primary cases, the disease process is strictly confined to the heart. Secondary cardiomyopathy describes condition in which cardiac involvement occurs as a part of systemic condition. Though there is considerable overlap, now the primary cardiomyopathy is divided into genetic, mixed, and acquired cause. Genetic cause include hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy or dysfunction, left ventricular non-compaction cardiomyopathy, glycogen storage disease, conduction defect, mitochondrial myopathy, and channelopathy, such as long QT syndrome, Brugada, short QT, catecholaminergic polymorphic ventricular tachycardia induced cardiomyopathy, and sudden unexplained death syndrome in Asia. And mixed include dilated and restrictive, acquired cause, inflammatory, stress provoked, that is Takotsubo cardiomyopathy, peripartum, tachycardia induced, and infant of insulin dependent diabetic mother. Acquired cause should not be confused with secondary cause of cardiomyopathy, which is associated with other systemic disease involvement. Now the secondary cause of cardiomyopathy is autoimmune or inflammatory, mainly the sarcoidosis, systemic lupus erythematosus, polyarteritis nodosa, dermatomyositis, endocrine, acromegaly, diabetes mellitus, thyroid disorder, obesity, and hyperparathyroidism. Infections such as Chagas disease, mycobacterial infection, rickettsial viral, particularly HIV, Coxsackie virus, Epstein, and recent outbreak, a pandemic outbreak of SARS-CoV-2 virus. And later on, I will show the pathogenesis of cardiomyopathy related to SARS-CoV virus. The other secondary cause of cardiomyopathy are infiltrative disorders such as amyloidosis, Gaucher's disease, neuromuscular disease such as glycogen storage disease, and muscular dystrophy, particularly nutritional disorder, particularly the thiamine deficiency, kwashiorkor. Toxins such as alcohol, anabolic steroid, chemotherapeutic agents such as doxorubicin, daunorubicin, chloroquine, heavy metal poisoning, iron excess hemochromatosis, radiation, and stimulants such as cocaine and methylphenidate. And though this classified American Heart Association and this classification is not complete, and ESC also classified cardiomyopathy as hypertrophic, dilated, arrhythmogenic, restrictive, and unclassified, each having again divided into familial and non-familial cause. Familial cause is again unidentified gene defect and disease subtype, non-familial, non-gene defect, and idiopathic and subtype. World Heart Federation, though this classification is not, no one is complete, World Heart Federation collaborated and proposed a Moses classification which attempt to integrate the morphofunctional phenotype-based description, information of the involvement of extracardiac organ or tissue, clinical genetics in familial disease, pattern of inheritance, and molecular genetics, disease of gene and mutation. The Moses has also described the sporadic non-genetic cardiomyopathy and specified their etiology if known. In case of phenotypical sporadic cardiomyopathy, a genetic origin of the disease cannot be excluded unless a non-genetic cause is proven, and clinical family screening has ruled out a familial disease. And the 5 attributes of Moses classification are M for morphofunctional, O for organ involvement, G for genetic or familial inheritance, E for etiological description of genetic or non-genetic defect, and functional status. And now this is the Moses classification. Morphofunctional include dilated, hypertrophic, restrictive, and organ involvement, either heart, cutaneous, or nervous system, or skeletal muscle is involved. Genetic cause is the familial involvement or non-familial, inherited autosomal dominant, and genetic etiology is obligate carrier or obligate non-carrier, and genetic cause also in details, and later on the functional status. And this is, I show here the 20 years old male with diagnosis of hypertrophic cardiomyopathy since he was 12 years old, grandfather and father history of hypertrophic cardiomyopathy, undergoing myectomy evaluation, presented with NYH class 3 heart failure. This is, if we describe the morphofunctional, aim is hypertrophic, organ involvement is heart, genetic is undetermined in that case, and etiological genetic test not ordered here. And the functional stage, American Association, Heart Association class 3, and New York Heart Association is class 3. This is the example of Moses classification. And Moses classification are also supported by Google Play Stores. Can utilize with this Play Store, we can use this classification also. And later on, and this is the proposed pathogenesis which I mentioned here in the pandemic outbreak of SARS-CoV-2 myocarditis, how it causes myocarditis. The pathophysiology of the COVID-19 related myocarditis is thought to be a combination of direct viral injury and cardiac damage due to host immune response. SARS-CoV-2 utilizes the spike protein to enter with the ACE inhibitor or two receptor enter into the cell and inhibit the stress granules formation so that it alive and multiply here, and it then intercellular SARS-CoV-2 might enter the stress granule formation by its accessory protein. Without stress granule, virus is multiply here. At the same time, it also activate the innate T cell and ultimately the CD8 T lymphocyte mediated cytotoxic cell damage occur. And the other is the inflammatory cytokine storm, in which the interleukin cell is released and other T cell is activated, and inflammatory marker causes myocardial damage. This is I show here because I show in the viral cause of myocarditis in the pandemic form throughout the world. That's why I show this slide here. But it is not clear whether it is causes the chronic myopathy. The paper and the data is still not available. So, thank you. Thank you, this friend.
Thank you, Dr. Asad, for your in-depth talk on classification of cardiomyopathy. By this time, Professor Fazila Madam, our prime initiator of this course, join us. Madam, do you hear me?
Yes, I can. I'm sorry. You know, actually, hello.
Hi. Yes, ma'am.
I can't see you also. So I'm having problems with my computer and I joined a bit earlier, but I could hear all of you, but I couldn't see you, which I can't do now also, and you couldn't hear me. So thank you for everyone being here. And I'm so grateful to our two panel experts who have come to share their knowledge with us. So welcome to our session, and we're really grateful. Thank you.
Thank you, madam. Assalamu alaikum, madam.
Welcome.
Okay. Now we can go to our second speaker. The question session is after the end of this session. Okay, sir. Our second speaker, Dr. Farad Jamal, his talk on idiopathic dilated cardiomyopathy. Dr. Farad?
Yes, sir.
Please share your slide.
Thank you, sir. My dear learning audience, Assalamu alaikum. My today's topic is idiopathic dilated cardiomyopathy. Idiopathic dilated cardiomyopathy is a primary disease of the heart muscle that is characterized by ventricular chamber enlargement or systolic dysfunction in the absence of chronic pressure and or volume overload or coronary artery disease that is sufficient to cause the observed myocardial dilatation in global systolic impairment. As Asad already have showed, it is a primary disease of the heart muscle, which may be involve genetic cause or some acquired myocardial cause. If you look at the spectrum of the idiopathic dilated cardiomyopathy, it evolves from its initial non-structural stage where there is no structural function abnormality. There's just some mutation carrier or post-myocardial stage, as for example, has evolved later to two clinical subsets. First one is non-dilated hypokinetic cardiomyopathy, where LV dispersion has started, but LV is not dilated. And finally, it becomes the full-blown dilated cardiomyopathy, where both LV dilatation and LV reaction ejection fraction will occur. Terminal dilated idiopathic dilated cardiomyopathy occurs in about 1/3 of the case of the case. Most of the cases are autosomal dominant, and truncated titin mutation and laminin mutation responsible for about 30% of the familial cases and 18% of the sporadic cases of familial cardiomyopathy. Cardiac manifestation usually becomes evident with increasing of the age. A third generation pedigree formation is mandatory for evaluation. If we want to diagnose in the relative, first we will diagnose the index case as per the criteria. There is dilated LV with reduced ejection fraction. If in the relative the criteria of index case are met, it is a definite case. If not met, then we have to look for some major and minor criteria for the relative. What is the major criteria? The unexplained disease decrease in the LV ejection fraction between 45 to 50%. Unexplained LV dilatation more than 2 standard deviation of normal. And minor criteria are complete LVV or atrioventricular block, unexplained ventricular arrhythmia, late gadolinium enhancement on the cardiac MRI, and evidence of non-ischemic myocardial abnormalities or endomyocardial biopsy, and serum organ-specific anti-heart muscle antibody. If any one of the major criteria are present, plus one or more of the minor criteria, it is probably a case of familial idiopathic dilated cardiomyopathy. Or if a mutation carrier is present, that is also a case. If these two criteria are absent, that is not possible. It is, if major criteria is not met, then two or more minor criteria or one minor criteria plus mutation carrier, that is a probable case of or possible case of familial cardiomyopathy. If you look at the epidemiology, the prevalence is about 1 in every 2,500 cases in general population. It is the third common cause of heart failure. It is the common cause of sudden cardiac death in young, and most common in third and fourth decade of life. Female sex has higher survival rate than males. Idiopathic dilated cardiomyopathy has a better prognosis than other types. If we want to evaluate the patient by history, we should focus on severity of the disease, any reversible cause of acute decompensation, duration of the disease, and rate of progression. And also important medical history, that history any secondary cause, that is for exclusion, or also for the genetic association. What is this? Family history of cardiomyopathy or sudden cardiac death. Any secondary cause like hypertension, coronary artery disease, anemia, thyroid dysfunction, alcohol or any drug abuse, prior history of heart failure or myocardial injury, anti-cancer medications, or any new medications, recent history of infections, any learning, hearing, visual disturbance, gait disturbance, muscle weakness, etc. Symptoms are good indicator for severity of the dilated cardiomyopathy, which may include fatigue, dyspnea on exertion, cough, orthopnea, paroxysmal nocturnal dyspnea, palpitation, edema, increasing weight or abdominal gas. The level of the cardiac decompensation or decompensation determines which sign will be found, like hypotension, tachycardia, irregular rhythm, tachypnea, jugular venous distension or hepatocellular reflux, cardiomegaly, that is seen by shifted apex, murmur of mitral regurgitation or acid regurgitation, paradoxical splitting and prominent pulmonary component of the second heart sound, third and fourth heart sound, S3 gallop, pulmonary edema, enlarged liver, ascites, and peripheral edema. What are the restrictions we should do in dilated cardiomyopathy cases? We should do complete blood count, test the cause, just like, for example, anemia. We have to do comprehensive metabolic panel, electrolytes, creatinine, magnesium, liver function test, thyroid function test, and iron status. ECG, chest X-ray, echocardiography, cardiac MRI with gadolinium, endomyocardial biopsy, and right heart catheterization in some cases. Cardiac biomarkers are sometimes important. As for example, in acute, if there is any acute or recent myocardial injury, myocarditis, or acute acute coronary syndrome as a potential etiology for acute decompensation. BNP or NT-proBNP is also important to help the monitor the presence of severity of the fluid overload and response to treatment. High level is associated with poor progress. ECG also important. It shows ventricular or associated with atrial enlargement, rhythm abnormalities like tachycardia, atrial fibrillation, previously ventricular complex, sustained or non-sustained VT or other arrhythmia, conduction disturbance block. There may be varying degree of atrioventricular block which may present in genetic form, that is laminopathy, or also in secondary causes. Extreme low voltage occurs in PLN mutation. Low PAV amplitude or pseudo-infarct pattern may be seen in cardiomyopathy associated with myotonic dystrophy. Cardiomegaly is a sensitive sign for diagnosis of the cardiomyopathy and is high predictive value for heart failure. Pulmonary vascular resistance with prominent pulmonary vasculature and upper lobe diversion and cardiac beeline may be present, and presence of this increase the 12-fold likelihood of having acute decompensated heart failure. Blood effusion may present initially on the right side, but it can be bilateral. Echocardiography is the first line investigation test on the patient with idiopathic dilated cardiomyopathy. It provides the pivotal information for diagnosis, risk assessment, guiding treatment, screening the family members, and exclusion of the different diagnoses like pulmonary embolism, brachial effusion with tamponade. Asymptomatic first-degree relatives of patients of idiopathic dilated cardiomyopathy should have an echocardiogram every 3 to 5 years or anytime if sign or symptoms occur. Stress echocardiography is another modality to see the contractile reserve. If it is less than 20% of the baseline, it is an adverse prognostic factor. Two major criteria for echocardiography diagnosis are increase in the LV dilatation, that is more than 2 standard deviation corrected for age and body surface area, plus LV ejection fraction of less than 45% and fraction shortening of less than 25% in the absence of a definite etiology. According to the British Society of Echocardiography, there are some echocardiographic prognostic markers. What are these? These are spherical index, that is LV based to apex to diameter ratio more than 1.5, L dilatation, dP by dt on continuous measurement from MRZ less than 600. Normally it is around 100 to 1000 to 1200 millimeter mercury per second. High grade LV diastolic dysfunction, LVOT VTI less than 18 centimeter, RBCC dysfunction, and raised RA PA pressure. These are the picture showing all these parameters that I have already described. It is also important to assess LV dysynchrony when CRTD is planned, or the criteria for CRTD, other criteria for CRTD is met. I'm not going in details. Cardiac MRI is important to see the extent of myocardial mid-wall fibrosis with late gadolinium enhancement, which assesses is a predictor of arrhythmia and failure to respond to treatment. Right heart catheterization is also important to demonstrate the elevated filling pressure, there is central venous pressure, pulmonary artery waist pressure, and decreased output. This is important in hemodynamically uncompromised patients. Clinical genetic testing, to whom we should do. Mutation-specific gene test is recommended in patients with idiopathic dilated cardiomyopathy to see whether there is any genetic subset or the familial cause or not. And for family members of idiopathic dilated cardiomyopathy patients, after the identification of the dilated cardiomyopathy causative mutation in the proband or in the index stage, or having some clinical clues, which I've already said, just like active ventricular block or low PO amplitude in PLN mutation. Endomyocardial biopsy is class 3 indication in some conditions, like recent onset and deterioration of the cardiac function, patient on doxorubicin, systemic disease of possible cardiac involvement, and inflammatory cardiomyopathy. That is to exclude other secondary causes mainly. Now, treatment of idiopathic dilated cardiomyopathy. There are modalities of medications, device therapy, heart transplantation. There are some investigational treatments, diet and activity, and cardiac rehabilitation. Symptomatic cases are managed following the current FCC-AHA and ESC guideline for heart failure with reduced ejection fraction. Individualized risk assessment determined by different etiology and genetic tests may dictate additional different treatment strategies. The goal is symptom relief, improvement of the cardiac output, shortening of the hospital stay, pre-emergency department visit, reversal of the injury process, and to decrease the mortality. Medication. Guideline-directed medical therapy that are used in cardiomyopathy are ACE inhibitor, ARB, beta blocker, aldosterone antagonist, cardiac glycosides, diuretics, nitrates, and vasodilators. Among these, ACE inhibitor, ARB, and beta blocker, they are the cornerstone in the therapy, and patient may be benefited even if they are asymptomatic even. Two newer medications I want to highlight. These are who have proven reduced mortality and morbidity. These are angiotensin receptor and FSC inhibitor, and another one is synastrial node modulator, ivabradine. And this updated guideline recommends this ACE inhibitor to shift from ACE inhibitor or ARB to angiotensin receptor blocker and neprilysin inhibitor in patients with class 2 to 3 symptom patients who are not responsive to treatment medication. And it is also said that even if it is given in patients who are responding to treatment, the benefit will occur. Ivabradine is recommended as an add-on therapy in systolic heart failure with ejection fraction below 35, sinus rhythm, resting heart rate above 70 beats per minute, and patient on maximum tolerated dose of beta blocker or intolerant to beta blocker. Antiarrhythmics, class antiarrhythmics like amiodarone and dupilumab are favored, but there is no mortality benefit. Human beta natriuretic peptide retard are used temporarily in patients with acute decompensated heart failure who dilates veins and arteries. Inotropes are reserved for hemodynamically unstable case, palliation, and as a disease-inclusive transplant. Anticoagulants are considered to reduce the risk of stroke in this cardiomyopathy patient with atrial fibrillation with additional risk of cardioembolic events. Device therapy. AICD and CRTD with or without concomitant ICD are recommended as per current FCC-AHA and ESC guidelines. I am not going in details due to time constraint, but one point I have to highlight: ICD should be considered in patients with confirmed NA mutation, having non-sustained VT, ejection fraction less than 45%, non-missense mutation, and NHF. And the assist device sometimes used as a bridge to transplantation or as a destination therapy in patients who are not candidate for heart transplant. There are some investigational treatments like gene therapy, intracoronary delivery of the sarcazine of the adenovirus is in phase 2 trial that is called QP2 trial, has shown a significant increase in the ejection fraction. The stem cell therapy is also tried. Injection of the skeletal myoblast as an autograft into the damaged myocardium, that is also under progression. And one device is also can be used. There is a called Cardiomyopathy, a wireless implantable pulmonary artery pressure monitoring system, which reduces hospitalization in a number of patients. Heart transplantation absolute indications are for heart transplantation are refractory cardiogenic shock, dependence on intravenous inotrope for organ perfusion, peak oxygen consumption less than 1 ml per kg per minute, or symptomatic ventricular arrhythmia, refractory to all therapy. Diet, activity, and cardiac utilization are as per SCN ESC guideline for heart failure. Now, it is also important management of the genotype positive or phenotype negative patient. That is, in the spectrum, that subclinical cases who have gene carriers. The current requirements are to observe of the asymptomatic case at high risk relative with yearly clinical assessment, control of the risk factors in this case like hypertension, smoking, and others, restriction from competitive sports, early restriction of the medical therapy when initial sign of ventricular dysfunction is detected. You have to assess certain cardiac death, like the points are reduced ejection fraction, cardiac MRI with late gadolinium enhancement, the presence of presumed arrhythmogenic syncope, non-missense LMNM mutation in laminopathy, and future guideline may include this as a for ICD implantation in future. There are some prognostic factors like heart failure with reduced ejection fraction, which are this LV and right ventricular enlargement, left or right ventricular ejection fraction and or right ventricular ejection fraction, persistent S3 gallop, right side heart failure, elevated RV filling pressure, pulmonary hypertension, left bundle valve block, recurrent ventricular tachycardia, renal and hepatic dysfunction, elevated level of BNP, peak oxygen consumption more than less than 10 to 12 ml per kg per minute, serum sodium less than 137 millimole per liter, advanced NHF functional class is more than 64, and myocytolysis on endomyocardial biopsy. Affected by cardiomyopathy is increasing. A complete family history mandatory in all. Judicious use of history, ECG, cardiac imaging is important to identify the phenotypic expression of genetic subset, which helps in risk stratification, prognosis, and targeted intervention. Genetic testing is being increasingly incorporated into the clinical practice. Guideline-directed medical therapy for heart failure with reduced ejection fraction, along with targeted intervention to specific genetic subset, is the treatment strategy in IDCM. But several questions still remain that needs prompt future investigation. There is correct treatment frequency and mode of follow-up in asymptomatic gene carrier and development of gene or mechanism-specific therapy. Thank you all for patient hearing.
Thank you, Dr. Farhad, for your brilliant speech covering all the aspects of idiopathic dilated cardiomyopathy. Now I move to our third speaker, Dr. Nazmun Laila. She is working as a registrar in our hospital and very talented and nice presenter as well. Dr. Nazmun Laila, please share your slide.
Thank you, sir.
Dr. Farhad, you have so many questions, so prepare yourself.
Assalamu alaikum, respected panelists, respected moderators, fellow speakers, and everyone listening to us here today. Welcome to our session, and I'll be talking about peripartum cardiomyopathy. Peripartum cardiomyopathy is an idiopathic cardiomyopathy presenting with heart failure secondary to LV systolic dysfunction towards the end of pregnancy or in the months following delivery, where no other cause of heart failure is found. It is basically a diagnosis of exclusion. The left ventricle may or may not be dilated at presentation, but ejection fraction is nearly always less than 45%. There are several diagnostic factors for PPCM. One is the idiopathic condition, that is, there's no detectable underlying cause of heart failure. A temporal appearance, that is, its presence during the last month of pregnancy or during the first 5 months postpartum. the absence of pre-existing known heart disease prior to the last month of pregnancy, and the presence of LV systolic dysfunction demonstrated by classic echocardiographic criteria, and LV ejection systolic dysfunction of less than 45%, a reduction in the fractional shortening of less than 30%, and additional dilatation with LV in systolic dimension of more than 2.7 centimeters per meter square. And usually PPCM patient regresses within 12 months of its onset. It occurs in 0.1% of all pregnancy, and the prevalence in the Western world is between 1:4,000 to 1:1,000 live births. However, there's some regional variation. In countries like Japan, it is as high as 1:20,000 live births, and in China as high as 1:40,000 live births. And there's some cultural factors, like the tradition of ingesting dried lake salts in Nigerian women postpartum while lying on a mud-heated bed twice daily for 40 days postpartum to increase the production of breast milk. And this has been directly related with the increased incidence of PPCM amongst the Nigerian women. Approximately 75% cases are diagnosed within the first month after delivery, and 45% occurs in the first week. The several risk factors, age above 30 years or even teenage pregnancy, multiparity, African origin, obesity, diabetes, smoking and other substance misuse, preeclampsia, eclampsia and chronic hypertension, malnutrition, and hot, humid tropical climates, and long-term, that is more than 4 weeks use of tocolytic therapy. So etiology involves a variety of factors. This has also been discussed previously by my previous speaker. Familial and genetic predisposition, particularly truncated variant in sarcomas. Almost 8 such mutations have been found. Maladaptive response to the hemodynamic stress of pregnancy. Viral myocarditis and systemization, where large amount of inflammatory markers and apoptotic factors as well as have been said to really cause PPCM. Malnutrition, particularly selenium deficiency of less than 70 micrograms per liter was seen to cause directly to peripartum cardiomyopathy. And there was also an increased predisposition to develop viral infections, hypocalcemia in these women. Fetal microchimerism, increased levels of fetal cells in the maternal circulation, and have been directly related to some form of autoimmunity, and that there's evidence that is also responsible of peripartum cardiomyopathy. Prolactin levels are high in pregnancy. However, lust has a lot of beneficial effects like retaining a good water electrolyte balance, secreting and erythropoietin, and maintaining hematocrit. But in the last trimester of pregnancy, there's some oxidative stress, and it causes this prolactin to be cleaved into a 14 kilodalton unit, if I'm not wrong, 14 kilodalton unit, and this is the particle that this microvascular damage, cardiac injury, has been said to be related to cardiomyopathy. So to know the physiology, in normal pregnancy, we have a hemodynamic response of pregnancy, which is increase in stroke volume, cardiac output, reduction in peripheral vascular resistance, reduction in afterload, increase in LV mass. And so we have a transient increase in left ventricular hypertrophy because of the structural and functional. However, with the protective cardiac myocyte signal pathways, this eventually returned to normal after delivery. The elevated levels of inflammatory cytokines, apoptotic factors, genetic factors like mutation in the TTN genes, microchimerism, which is directly related to autoimmunity, and deficiency of micronutrients like selenium. This has eventually led to onset of peripartum cardiomyopathy. Clinical features of cardiomyopathy are the features of heart failure. So these symptoms include dyspnea, paroxysmal nocturnal dyspnea, orthopnea, cough, chest pain, anorexia, fatigue, and edema. And signs include raised JVP, tachycardia, tachypnea, hepatomegaly, hepatojugular reflux, ascites if there's right heart involvement, with pitting edema and evidence of thromboemboli. Cardiac findings include a loud third heart sound, gallop rhythm, the systolic murmur of mitral regurgitation, a loud splitting of second heart sound, and bilateral preps. However, these patients now may usually present with acute heart failure, but it is not unlikely that they may present with some form of arrhythmia, chest pain, or even cardiac arrest. Diagnosis is confirmed after inclusion of the following differentials, like uncomplicated pregnancy, accelerated hypertension, pulmonary edema secondary to eclampsia or preeclampsia, pulmonary embolism, pneumonia, myocardial infarction, previous valvular heart disease, and diseases like anemia, thyroid disease, and of course, idiopathic dilated cardiomyopathy. This is a figure showing the differentials and how they differ. In a peripartum cardiomyopathy, it has a temporal incidence, that is, it occurs just before pregnancy or postpartum, and the elevated biomarkers of BNP is raised. Echo will show evidence of LV dysfunction and in occasions right heart involvement as well, and this is confirmed with the MRI. In a patient with pre-existing cardiomyopathy or valvular heart disease or congenital heart disease, the onset is usually at an earlier stage, usually during the second trimester, and there may be the presence of a family history. Again, natriuretic peptides will be raised, and they'll previous echo might reveal a pre-existing valvular heart disease or a congenital heart defect, and these are confirmed with an MRI or subsequently genetic testing. Pregnancy-associated myocardial infarction, the patient will have a typical retrosternal chest pain with abdominal discomfort, nausea, vomiting, and markedly raised troponin. And on echocardiography, there will be either regional hypokinesia or akinesis, and this is confirmed with a coronary angiogram. In patients with pulmonary embolism or amniotic fluid embolism, this is a typical pleuritic chest pain on history. There will be elevated biomarkers like D-dimer will be raised troponin, and even BNP may be raised. Echocardiography will show RV dysfunction, elevated RV pressure, and McConnell sign. And this is confirmed with a CT scan or a ventilation perfusion scintigraphy. Myocarditis, the patient will usually give a viral prodrome or a history of an infection prior to its presentation with a more or less raised troponin I and elevated natriuretic peptides. On echocardiography, there will be regional or general hypokinesis. This is confirmed with an MRI, as I'll be describing in a few slides later. On investigation, there are several blood tests that are done to exclude the other causes of heart failure. These tests are a complete blood count and its differential, urea, creatinine, electrolytes, particularly magnesium and calcium, thyroid function test, and the liver function test. ECG will show sinus tachycardia with non-specific STT changes. Ventricular arrhythmia may occur, and rarely atrial fibrillation may be seen. B-natriuretic peptide are very sensitive biomarkers of a heart failure, and its elevated levels are directly have prognostic significance as well. On chest X-ray, cardiomegaly, usually LV apex type, may be seen with features of pulmonary congestion, oligemic lung fills, and pulmonary hypertension with pleural effusion. However, chest X-ray may give a false impression as heart is pushed upwards and laterally during pregnancy. This is a ECG, as most of the patients present with acute heart failure, this ECG reveals sinus tachycardia. And this is a chest X-ray showing cardiomegaly. Echocardiography is the imaging modality of choice. It shows both ventricular enlargement and global reduction in the contractility and function. LV and diastolic dimension will be usually more than 52 millimeters, with the presence of severe, moderate to severe mitral regurgitation with or without tricuspid regurgitation. LV ejection fraction is usually less than 45%. Echocardiography also assists in excluding other structural causes of heart failure like myocardial infarction, underdiagnosed valvular heart disease, the presence of HOCM and atrial myxema. An initial presentation of LV ejection fraction less than 30% with marked LV dilatation where the end diastolic dimension is more than 60 millimeters and the right ventricle involvement or presence of an LV thrombus, these are associated with adverse outcomes. This is the echocardiographic of a typical peripartum cardiomyopathy patient showing a enlarged left ventricle with global hypokinesia. MRI is usually avoided in pregnancy, but in certain cases may be important to identify the mechanism involved. Furthermore, delayed contrast enhancement with gadolinium helps differentiate the type of myocyte necrosis that occurs in myocarditis versus ischemia. In myocarditis, it is a subepicardium involvement and non-vascular distribution, whereas in ischemia, it is a vascular distribution with a subendocardial or transmural involvement. Assessment and management of pregnant patients with the PPCM is a joint cardiac and obstetric care, often requiring the involvement of an anesthesiologist, neonatologist, and even cardiac surgeon. Serial echocardiogram and serum natriuretic peptides and fetal ultrasound are also very important. General management, including restricting low sodium diet, fluid restriction, encouraging moderate exercise in the form of walking, and smoking cessation. Treatment of coexisting conditions like anemia, diabetes, hypertension, thyroid disorders, and nutritional deficiencies are also very important. Oral pharmacological therapies are those of heart failures, as some of these drugs are fetotoxic. So during prepartum, hydrolysine nitrates, the main intention is to improve preload, reduce afterload, and increase contractility of the LV. So in prepartum, hydrolysine nitrates, diuretic digoxins, and beta blockers may be used. And postpartum, ACE inhibitors and ARB, which are the most potent drugs, may be added in addition to the others. Heart failure with pulmonary congestion are treated with loop diuretics and thiazide diuretics. However, this must be done very cautiously because there's a chance of reducing the placental blood flow. Fetotoxic agents like ACE inhibitors, ARB, ARNI, MRA, and atenolol are all avoided in pregnancy, but hydrolysine and nitrates can be used instead in decompensated heart failure, severe LV systolic dysfunction, and cases of heart hypertension. Beta blockers are initiated cautiously and gradually titrated up to the maximum tolerating dose. A high resting heart rate is a predictor of adverse outcome, and treatment in ivabradine may be used for postpartum and in non-breastfeeding mothers. Patients who are in cardiogenic shock and are totally dependent on inotropes, the preferred inotrope in this case being a levosimendan, and other vasopressors are transferred for mechanical circulatory support with at the same time urgent cesarean section, irrespective of the duration of gestation of the fetus, are advised. Rapid tapering of heart failure may lead to relapse of peripartum cardiomyopathy. Thus, treatment should be continued at least for 6 months after full recovery of the LV function, followed by gradual tapering. Bromocriptine may improve LV recovery and clinical outcome in such patients. Other drugs that may improve outcome include pentoxifylline, TNF-alpha antagonists, and certain immunoglobulins. Pregnancy itself is in a hypercoagulable state, so anticoagulants play an important role, especially if the left ventricular ejection fraction is less than 35%, if there's evidence of paroxysmal or persistent atrial fibrillation, if there's a documented LV thrombus, systemic embolism. Warfarin and low molecular weight heparin or unfractionated heparin may be used in pregnancy as recommended in the guidelines. Acute peripartum cardiomyopathy has been summarized under the board label, where B stands for bromocriptine, which counters the effect of prolactin and the detrimental effects of its fragment. O stands for oral high heart failure drugs. A stands for anticoagulants, R for vasodilators, and D for diuretics. A wearable cardioverter defibrillator may prevent sudden cardiac death in the first 3 to 6 months after diagnosis, especially if the ejection fraction is less than 35%, allowing for the patient to recover from severe LV systolic dysfunction. However, in severe LV systolic dysfunction that extends to 6 to 12 months following optimal medical management, implantation of ICD and CRT are recommended according to the guidelines. Cardiac transplantation is reserved for patients where mechanical circulatory support is not possible, and patients who do not recover despite optimal management even after 12 months. However, there's a high rate of graft failure and death after heart transplantation. Urgent delivery, irrespective of the gestation duration, is advised in all patients with advanced heart failure and hemodynamic instability. Cesarean section with central neurexual anesthesia is recommended in such cases. In stable congestive heart failure, vaginal delivery is preferred with a spinal or an epidural anesthesia. Breastfeeding is discouraged in the severe symptomatic cases because stopping lactation reduces the high metabolic demands and enables early optimal heart failure management. This is a chart showing advanced heart failure during pregnancy, induction of lung maturation, and multidisciplinary approach involving cardiologists, obstetricians, neonatologists, anesthesiologists, and to look for the status and prognosis of the fetus. If the fetus is non-viable, immediate cesarean section is advised with continuation of maximum advanced heart failure therapy for the mother. If the fetus is viable, and parents are consulted for their opinion, and either delivery is continued with maximum possible advanced heart failure therapy, or pregnancy is continued while closely monitoring the mother and fetus. This is another chart showing the approach to a patient with advanced acute heart failure. Initial assessment with hypertension, tachycardia, tachypnea, and saturation less than 90%. So the patient can be described to be in severe acute heart failure or cardiogenic shock. Optimize preload and give vasodilators if the systolic blood pressure is more than 110 millimeters of mercury. Add a good inotrope again. Levosimendan at 0.1 microgram per kg per minute is the preferred inotrope. Optimize oxygenation initially with oxygen followed by non-invasive ventilation, and finally invasive ventilation when required. And urgent delivery with cesarean section using neuroaxial anesthesia. Consider bromocriptine after the postpartum. During this time, mechanical circulatory support may be given to the mother, and with time, if she recovers, when she's weaned off to stable acute heart failure, or if she does not recover, then she's put for a bridge to transplantation. Stabilized acute heart failure may be treated according to the patient status, antepartum or postpartum. Antepartum, she's given the heart failure management followed by vaginal delivery with epidural anesthesia. And postpartum, heart failure management, including the ACE inhibitors or ARB, is given here, followed by bromocriptine. If the patient is symptomatic, despite optimized medical management, a variable cardioverter defibrillator may be given if the risk of sudden cardiac death is very high, particularly if the ejection fraction is less than 35%, while continuing the management of heart failure. On follow-up, echocardiography is to be repeated at 3 months, at 6 months, and then after diagnosis to monitor for functional recovery, and subsequent annual follow assessments is advised. Measurement of inotropic contractile reserve during dobutamine stress echocardiography correlate well with subsequent recovery of LV function. Patients with little or no recovery should be committed for lifelong pharmacological therapy. However, those that do recover and completely and stay so may have their drugs gradually withdrawn with careful monitoring. The question of subsequent pregnancies is very important. Persistent in patient with persistent LV systolic dysfunction, there's a high risk of relapse of more than 50% with further deterioration of LV dysfunction. And there's increased mortality and morbidity associated with subsequent pregnancy. Even premature delivery and abortion may occur. So these are strictly advised against further conception. Patients who have completely recovered show a better prognosis with subsequent pregnancies. However, because of the impaired cardiac LV contractile response that occurs even following ejection fraction above 50 to 55%, there's a 20% chance of relapse. But the rate of recovery is better. There's less morbidity and mortality, and patient is likely to have a normal pregnancy. So she may be advised to continue a pregnancy with close monitoring of both fetus and mother. Approximately 50% of women completely recover in normal LV size and function within 6 months of delivery. And this is best if the ejection fraction is more than 30% at the time of diagnosis. The remaining either have a stable LV function or may experience clinical deterioration. Maternal mortality is between 6 to 10%. Poor prognostic factors are women more than 30 multiparity African origin are high troponin I levels, presence of LV thrombus, and a white QRS complex. And women with peripartum cardiomyopathy and persistent LV dysfunction or LV ejection fraction less than 25% at presentation have the worst clinical outcome and are at increased risk of complication in subsequent pregnancy. Peripartum cardiomyopathy recur in 20 to 30% cases, even if LV function normalizes because of the abnormal contractile reserve. And this may lead to significant clinical deterioration and death. I hope I was informative enough. Thank you for allowing me to present at this podium.
Thank you, Dr. Nazmul Laila, for your very enlightening speech regarding a very important issue in our daily practice, that is postpartum cardiomyopathy. And you have covered all the aspects, including prognosis and subsequent pregnancy if the patient wants to have again. Our next speaker and the final speaker, Professor Dr. Nazir Ahmed sir, his talk on ischemic cardiomyopathy. Professor Nazir sir, please share your slides.
Good evening, everybody. Welcome you all in this session. I am talking about ischemic cardiomyopathy. The definition of ischemic cardiomyopathy is commonly defined as a dilated cardiomyopathy in a subject of history of myocardial infarction or evidence of clinical significance, where 70 or more than 70% narrowing of coronary arteries, and in whom the degree of myocardial dysfunction and ventricular dilatation is not explained solely by the extent of previous infarction or degree of ongoing. In a nutshell, we can say that ischemic cardiomyopathy is a disease of the heart muscles, and from the coronary artery disease and the heart attack. Ischemic myopathy is left ventricular failure overlap hoche, which is main pumping of the chamber of the left of the heart and becomes distended, and ultimately patient develop heart failure. That is the ischemic cardiomyopathy. There are a lot of symptoms in ischemic cardiomyopathy. It is already common with the dilated cardiomyopathy. That is the shortness of breath, chest pain, swelling of the legs, feet, and abdomen, cough. Everything is here. Problem is here. There is the coronary artery occlusion. After coronary artery occlusion, what are the outcomes? Outcome depends on the occlusion of the coronary artery and the duration of the occlusion. If it is incomplete and short duration, and it becomes normal of the cardiac muscles and its function. But when the duration is relatively higher than that of the normal, then it develops ischemia and hibernating myocardium. When the complete occlusion with a short time, at least 5 to 10 minutes, followed by reperfusion. This is the standing of the myocardium, where muscles are normal, but it becomes, cells are normal, but its activity sometimes requires some days, months, sometimes. And when complete occlusion of the coronary arteries and prolongation of the coronary arteries, ultimately total occlusion, it causes immediately acute closure, acute myocardial infarction, followed by contractile failure, followed by fibrosis of the muscle, ultimately development of the ischemic cardiomyopathy. Another option is coronary artery disease or coronary microvascular dysfunction. This causes acute myocardial infarction, either ST elevation myocardial infarction or non-ST elevation myocardial infarction, silent ischemia, recurrent small infarction. All of this ultimately goes to ischemic cardiomyopathies. It may be diastolic or systolic or both of systolic and diastolic. There are a lot of investigations that are needed for ischemic cardiomyopathies. ECGs, X-ray chest, echocardiography, MPI, and cardiac MRI, and single photon emission tomography, coronary angiograms. Coronary angiograms sometimes is very helpful for our ECG. What about ECG? Sometimes in early stage, ECG may be normal. Sometimes it causes tachycardia, found tachycardia, non-specific T inversion, HTT changes, poor progression of the ROS in anterior leads, Barnes block, and some arrhythmias, especially atrial fibrillations, non-sustained ventricular tachycardia, multiple preventricular extrasystoles, etc. And chest X-ray, sometimes X-ray becomes normal in very early stage, followed by cardiomegaly. When the shows the moderate to gross cardiac diameter with heart failures, sometimes it found some pleural effusions and signs of pulmonary edema. Echocardiography is the main diagnostic tool for our diagnosis in ischemic cardiomyopathy, because ischemia is very important for ischemic cardiomyopathies. That is the symmetrical segmental wall motion abnormalities is the prime things. The definite area of akinesia or wall thinning is the suggestive of ischemic cardiomyopathy. Ischemic cardiomyopathy causes reduced ejection fraction, chamber dilatation, functional changes in the valves. It causes mitral valve regurgitation, tricuspid regurgitations, sometimes long-term causes pulmonary hypertension, diastolic dysfunction, and RV dysfunctions. There is a picture here showing that echo for heart failure signs or symptoms. The heart failure increase the LV size and decrease the systolic functions. It two ways, that is the global ischemia and regional wall motion ischemia. Regional wall motion ischemia is the ischemic cardiomyopathy, and global, that is the dilated cardiomyopathy. Here the two pictures are here. On the right side, that is the dilated cardiomyopathy. On the left side, that is the ischemic cardiomyopathy. Dilated cardiomyopathy, we can see all the chambers of the heart are dilated. But in ischemic cardiomyopathy, LV is dilated at its apical part with thinning of the interventricular septum and lateral walls also, and also some dilatation in the LA. But RB and RA are relatively normal. Regarding dobutamine stress echo, viable myocardium shows an increase in wall thickening and endocardium in response to low doses. In higher doses, dobutamine causes thickening of the normal myocardium, but sometimes it's hypokinetic akinesia in where there is a stenosis of the coronary arteries. Regarding ischemic cardiomyopathy, cardiac dilatation is due to cardiac remodeling. And this is why after myocardial infarction, there are a lot of changes. The events of changes are, initially there's an expansion of the heart from its elliptical shape into spherical shape in course of time. And immediate acute myocardial infarction decrease the myocardial mass, ultimately contractile capacity is reduced, increase the residual volume, ultimately this spherical heart increase the parietal tension increases with eccentric hypertrophy due to the new humeral activations and increase the growth factors. And another one is injury after myocardial infarctions. What of the changes occurs in there? There is the myocyte loss, toxic and some inflammatory changes, genetic, volume overload, pressure overload, after remodeling of the myocardium, there is all changes, genetic, myocardial, molecular, cellular, structural, ultimately develop ventricular dysfunction. Early stage, it is asymptomatic, followed by symptomatic. There, the pharmacological treatment of cardiac remodeling is divided into 3 strategies. One is consolidated, another one is promising, and a potential. Just pharmacological treatment is here. There's the consolidated area is, first of all, we are treated with this ACE inhibitor or angiotensin receptor blocker or beta blockers. Some promising treatment with the drugs is LCZ696, means Entresto, that is soquelitinib and valsartan. And other potentials are the diuretics, metformins, cyclosporin, etc. Regarding management of ischemic cardiomyopathy, there is lifestyle changes, there is lifestyle modifications, medical managements, medical management with the drugs and with the lifestyle modifications, and revascularization either by interventional revascularization or by CABG. Sometimes surgical intervention, surgical procedure is very important for reconstruction of the ischemic part of the left ventricles in ischemic cardiomyopathy. This is the medical treatment. What is the aim? To improve the cardiac functions, to treat the symptoms and prevention of complications. And there are a lot of drugs we are using later on, you see that the options of cardiomyopathy just is a chart is here, non-pharmacological, the diet in salts and low diet and fluid restriction, healthy body weight, smoking cessation, avoidance of alcohol, and vaccination schedule is very important, and some exercises in required for these patients. And pharmacological are these diuretics, beta blocker, ACE inhibitor, ARV, mineralocorticoids, ibabradine, sacubitril, and valsartan. Interventional procedure. They are the ICD, CRT, sometimes CRT-D, left ventricular assisted device, and cardiac ablation, and some surgical procedures I will discuss later on. Regarding ACE inhibitors, there is an angiotensin aldosterone mechanism where the problems created for dilatation of the left ventricles. Here, there are a lot of stages here from the angiotensinogen to angiotensin 1. Here, there's the direct renin inhibitors we can use there here. Angiotensin 1 to 2, it is the most common site where we are using ACE inhibitors, and the angiotensin 2 to aldosterone, angiotensin receptor blockers, sometimes aldosterone to target organ, the aldosterone antagonist, sometimes target organ to increase sodium retention, potassium excretion, and sodium retention. Here the mineralocorticoids, we are using this one. ACE inhibitor is very important in ischemic cardiomyopathy because it causes attenuated the short-term response of heart failure, prevents the increase in preload and afterload, and dampen the sympathetic response, reduces the vasoconstriction. ACE inhibitor may attenuate the long-term response to heart failure, attenuated the growth response to heart failure. And long-term response to heart failure with the angiotensin 2 promotes the growth of systolic heart failure and the diastolic heart failure. What is the problem with the systolic heart failure? Eccentric myocyte hypertrophy, interstitial fibrosis, overall dilated the ventricles, decrease the blood supply, functional regurgitation. At the same time, diastolic heart failure increase the myocardial mass, and fibrosis, ultimately concentric hypertrophy. ACE inhibitor, there are the clinical evidence lot of trials. There are many trials on AC inhibitor over last 20 years. Overcome the measures are symptomatic improvements by AC inhibitors, and disease progression is reduced by AC inhibitors, decreased mortality and morbidity by the AC inhibitor in different study has shown that. The effect of AC inhibitors on morbidity and mortality. Consister trial 1986 has shown first that AC inhibitor decreases the mortality rates in severe heart failure patients. Reduction of death due to preventing the progression of heart failure. SOLVE trial 91, it also shown the decrease the both the morbidity and mortality in severe heart failure. And also in 1992-93 has shown the same result. Increases the ejection fraction, decreases the ventricular dilatation, both the symptomatic and asymptomatic patients. The use of AC inhibitors in post-myocardial infarctions. There are a lot of trials is seen, the SAFE trials, and AR trials and TRACE trials, the captopril, ramipril, and tenelipril. Here we can see that decrease the risk of all causes of mortality is reduced by AC inhibitor 19% in SAFE trial, AR trials is 27%, and TRACE trial is 22%. Regarding beta blocker in ischemic cardiomyopathies, carvedilol is the drug of choice in congestive heart failure patients because it blocks both the beta 1, beta 2, and alpha 1 receptors. It is potential antioxidant effects, even it is 10 times higher than that of a vitamin E antioxidant effects. Beta blocker blocks the production of angiotensin 2 and suppresses the synthesis of endothelins and antiproliferative activities. Here we can see the total beta blockers in congestive heart failure, all cause of mortalities. The US carvedilol program has shown that carvedilol decreases the mortality, is very good numbers, and risk the reduction is about 65%. And CBS2 trial has shown with the bisoprolol, there is a risk reduction is 34%. And merit with the metoprolol risk reduction also 34%. After myocardial infarction, lot of events going on. After myocardial infarction, that the injury of the myocardium and insufficient of the myocardium is supplied, it causes decrease the myocardial contractility, ultimately decrease the peripheral perfusion. It causes the sympathetic activations, that the overactivity of the sympathetic activity. It ultimately results the increase desensitization of the beta adrenergic receptors, which ultimately again causes decreased cardiac contractility. At the same time, it reduces the cardiac myocyte damage and apoptosis and interstitial fibrosis and arrhythmias. These arrhythmias ultimately causes the death or disable sometimes. At the same time, when myocytes are damaged and interstitial fibrosis is there, their cardiac remodeling ultimately very dangerous condition. Long term, it causes different types of problems. Revascularization is very important because in ischemic cardiomyopathy, whether revascularization is work or not, especially what type of revascularization is required for the patient of ischemic cardiomyopathy. It is found that 7% absolute reduction in overall mortality, a 10-year time between patients with CABG versus optimum medical treatments. And CABG still improves the left ventricular functions, about 20 to 50% of the patient diagnosis with chronic left ventricular functions with significant amount of viable myocardiums. Several study has shown that CABG still is the best option in ischemic cardiomyopathy than that of the PCI, because there is no basic study in between CABG, PCI, and optimum myocardial, optimum medical treatments. But it is found that still CABG is the gold standard for the patients. Some stem cell therapy in ischemic cardiomyopathy, they are the roots of stem cell transport modalities to the heart muscles. They are the intramyocardial procedures, or the intracoronary artery procedures is there, or intravenous procedures, and transendocardial procedures. There are a lot of study has shown that cardiac stem cell in patients with ischemic cardiomyopathy, initial results with randomized trials are encouraging. They suggested that the intracoronary infusion of autologous coronary stem cells is effective in improving the left ventricular functions and reduces the infarct size in patients with heart failure after myocardial infarctions. Again, the stem cell therapy in chronic ischemic heart disease and the heart failure, it is shown that bone marrow treatment with bone marrow cells, these cells reduces the mortality and improves the left ventricular ejection fraction over short and long time follow-up. And incidence of non-fatal myocardial infarctions also reduced and improves the NYHA classifications with chronic ischemic heart disease and congestive heart failures. Device therapy in ischemic cardiomyopathy. Ischemic cardiomyopathy, device ICD therapy in LV systolic dysfunction or ischemic cardiomyopathy, the absolute mortality reduction of 7.9% by prophylactic use of ICD be compared with the 6.1% reduction in affordable AC inhibitors and beta blockers only for 4.4% in patients with LV systolic dysfunctions. And aldosterone antagonist reduces the mortality by 2.3%. But when beta blocker and AC inhibitor use, ICD has a beneficial effect over them and in medical treatments. CRT also important for disinfarction of ischemic cardiomyopathy. It improves the survivability of the patients, decreases the symptoms of the patient, increases the exercise capacity of the patient. Ultimately, patient's quality of life is improved with CRT, sometimes added with CRT with defibrillator CRT-D. These are the common indications for ICD and indication for CRT. This is the secondary preventions. We are talking about the primary, that is the when severe impairment of the left ventricular function where ejection fraction is less than 35%. NYSA classification 4A, despite optimal medical treatment more than 3 months, and ischemic cardiomyopathy, sometimes not ischemic. These are the level of evidence in the patients with ICDs. And indication for CRT, class indication is that the severe impaired left ventricular function, same as the before one, despite the optimum medical treatment for more than 6 months, and LVV in differential with different durations has shown the different levels of level of evidence for indications CRT. Regarding surgery, surgery of left ventricular reconstruction surgery is very important. Reconstruction surgery is required for the improvement of the left ventricular function, for the improvement of the quality of life of the patients, for the improvement of their survivability. And what are the reconstruction surgeries? This is a picture where we can see there is a fibrous tissue is in the left ventricles. And these fibrous tissue are cut and it is exceeded, and there is a suturing is here with a pericardial patch or some other patches is there, and reduce the size of the left ventricle. When left ventricular size is reduced, it increases the force of contraction, increases the workload, increases the ejection fraction, and patient feels better than previous one. And that's why it is still better, and survival rate also in better in these patients. This is the another one is, it is a suturing surgery. Just it suture the scar part of the fibrous part of the left ventricles. Left ventricle just scar, and this one in clip two areas in this junction, and just it reduces the size of the left ventricle, and the total muscles are theirs. Next one is another study has shown the influence of the baseline left ventricular function on clinical outcomes in surgical ventricular reconstruction in patients with ischemic myocarditis. That is the STREETS trials. STREETS trial has shown when the ventricular size is small and the force of contraction, the ejection fraction, and patient well-beings are better than that of the normal ischemic cardiomyopathy patients. And another one is surgical ventricular restoration. There is the RESTORE group experience. In this study, they are shown that these study has shown that this type of surgery improves the ventricular functions and is highly effective therapy in the treatment of ischemic cardiomyopathy, with the excellent result for last 5 years. Next one is surgery for heart. That is the heart transplantation. Ischemic cardiomyopathy for heart surgery is definitely problematic, but some indications is required for transfer the patient to surgery. And these are the indications where the severe heart failure, that is the American College of Cardiology, American Heart Association stage 4, and NY is a class 4, Y is a class 3 and 4, poor short-term prognosis despite medical therapy, require continuous inoactive support, require mechanical supports, that is balloon pump, ventricular assisted device, and ECMO. These are all requires continuous process, but no improvement is found. Then we are sending the patients to surgery for transplant of the cardiac surgeons. And what is the prognosis? Prognosis of ischemic cardiomyopathy is the patient with ischemic cardiomyopathy have a worse prognosis, about 50% death in first year. Prognosis is worse prognosis. About 50% patient with ischemic cardiomyopathy will die within 2 years of initial stages, and diagnosis and mortality rates is about 4% per year thereafter. There are poorer prognostic features of the patients where there is a atrial fibrillation, when left ventricular end diastolic volume diameter is more than 76 millimeter, increasing the mitral regurgitations, waist pressure is more than 16 millimeter, myocardial oxygen consumption less than 50, and restrictive pattern of filling. Thank you all.
Thank you, Professor Nazir Ahmed sir, for your very nice and informative lecture covering all the aspects from definition to modern treatment and all, including all studies. Now session is open, the time is short. Session is open for our expert panelists and other faculties also.
Assalamu alaikum. Can I add something?
Please,
Yeah.
please come forward.
It was all, thank you all the speakers. They have elaborated descriptions of all the cardiomyopathy forms. But for the students, I should mention that we get lots of dilated cardiomyopathies. Other than ischemic cardiomyopathy, there are some things we should consider in our mind, that we should look for anemia. So peripartum cardiomyopathies, then autoimmune diseases like systemic SLEs and sclerodermas, and some drug abusers, they also come with dilated DCM, and hypothyroidism, and some Takasubo. We should remember these things. And another thing, there are some cardiomyopathies, they don't revert, usually they reverse. So these are the cardiomyopathies like Takasubo, almost all recovers. So peripartum, already Nazmoon has mentioned, they have full restoration of function in case of 50% patients, and improvement of the LV function in 60 to 100%. And some alcohol cardiomyopathies, they also completely revert. There are some tachycardia-induced cardiomyopathies like HL, so they revert almost 80% full recovery after the treatment of tachycardia. And also hypothyroidism, they also have complete recovery, 90% of the patient recovers. So these are the things I want to mention. And another thing, the new statements in ESC guideline, heart failure, this is heart failure guideline. We already know that heart failure reduced ejection fraction, heart failure preserved ejection fraction. There are some other terms they have mentioned that heart failure with mid-range ejection fraction, between that is the ejection fraction between the 40 to 49%. And other terms, some of the new terms I should mention for the students, that heart failure with increased ejection fraction. This is also a newer term. So the patients have ejection fraction more than 40% now, but previously it was documented less than 35. And another one is heart failure with recovered ejection fraction. So those who have ejection fraction, before it was less than 50, but now it is more than 50. And another thing I should mention that when we get a dilated cardiomyopathy patient, we should receive, so we should think about something like, are we missing any treatable causes, and that my treatment is appropriate or not? Is there any benefit for CRT? So we should consider these things, and we should be screened for family. And for the advanced modality, we should screen and for do echos. And in echo, other than the LV function, we should measure the RV function, and especially the nowadays GLS. And we should look for some thrombus, because it just changes the modalities of treatment, because we have to add warfarin or neuroanticoagulants. And we should look for LV, LA volume index, and LS strain. And another important thing, that functional MR. So these functional MR after treatment, I think there are some treatment options like mitral clips. We don't have these kind of treatment. We just see in advance when we go to the conferences. So mitral clips, I think it helps to reduce the symptomatic improvement of the patient, mitral clip. Another thing I want to mention for the another thing that for Najmun, is a X-ray can be is safer in pregnancy? I don't know. She has shown the X-ray films. So another thing that the anti-beta blockers. So Farhadan mentioned, I think the bisoprolol and other, but I think nebivolol is not mentioned, but nebivolol is also a good option for heart failure, and it has a cardioselective action. And for the peripartum cardiomyopathy, there is a algorithm. I think ESC guidelines have used. They have shown we should check the LV ejection fraction. And if the ejection fraction is less than 55, so we think as a high-risk patient. So she cannot be get pregnant in high-risk cases. And if her ejection fraction recovered of more than 55, and then we should stop. After 1 year, we should stop the drugs like AC inhibitor or ARB beta blocker. Then we should monitor the ejection fraction. If the ejection fraction is more than 55, so we could consider it that the risk is relatively low. She can get pregnant. But if the ejection fraction again goes down, then she is an intermediate risk and she cannot get pregnant afterwards. So these are the things I wanted to mention. And thank you everyone. Thank you Nesar Bhai, thank you madam, and Najis sir. Thank you for giving me a chance for this session. Thank you very much. Nesar Bhai.
Dr. Nur Alam? Hi. Dr. Nur Alam, any comment for our attendees, especially for the students?
Thank you, Nesar Bhai. I'm very much delighted to be present here. I must thank the organizer, especially Fozila ma'am. And I also want to thank today's presenters. They almost cover everything. Just I want to put a few comments for the students regarding the examination perspective. Cardiomyopathy actually is a very important topic for exam in both written as well as clinical exam. In written questions, frequently the questions appear like classify cardiomyopathy. That is very nicely deliberated by Dr. Asad. And though he shown many types of cardiomyopathy, but it is good to remember everything. But if time constant, then the accord, mixed, and genetic, this classification is very important. Students can remember this on. And others form of written examination may come like this. There are some clues giving features of heart failure and some additional clues for a specific cardiomyopathy. Clue they have to answer like differential diagnosis of all cardiomyopathies. So this type of question may appear in the written as maybe a short question like peripartum cardiomyopathy or Takushubo cardiomyopathy. And another important is examiners like this topic is very much differentiation between arrhythmogenic right ventricular dysplasia or restrictive cardiomyopathy with constrictive pericarditis. This is a very important question. Restrictive cardiomyopathy and constrictive pericarditis differentiation, examiners like this. And as well as in clinical, there is a if your long case for the students, if the long case is aortic stenosis, you must be asked differentiation between hypertrophic obstructive cardiomyopathy and aortic stenosis in clinical scenario, or will be the differentiation. If your case is aortic stenosis, you must ask the differentiation between hypertrophic obstructive cardiomyopathy. So these are the tips, and I will not continue more. I again thanks the organizer for giving me the opportunity to be here. Thank you. Thank you, everybody.
Thank you, Dr. Nur Alam. I think hypertrophic cardiomyopathy, it will be another session for this course. And we have some important question, especially for the Nazir sir, and then Nazmun Laila and Dr. Farhad. Can I discuss here from? Time constraint is up, sir. Do you have time? Enough time?
Discuss karo.
Yes, sir. We have enough time.
Sir, Nazir sir, is there any demarcation of ejection fraction for defining ischemic cardiomyopathy? Nazir sir, is there any demarcation of the ejection fraction, percentage of ejection fraction for defining ischemic cardiomyopathy? কার্ডিওমায়োপ্যাথি ডেফিনিশন দেওয়ার জন্য কি ইজেকশন ফ্র্যাকশন কোনো ইম্পর্টেন্ট কোনো ডিমার্কেশন আছে? 38%, 45%, 40%, এনিথিং এলস?
Basically, ischemic cardiomyopathy itself indicates there is a reduced ejection fraction. Usually, average 45 to 45% or below is the cardiomyopathy. It may be ischemia due to 35-40 is okay. It's not bad at all. Ejection fraction definition যদি বলতে হয় তাহলে আমার মনে হয় যে ইজেকশন ফ্র্যাকশন দিয়ে কার্ডিওমায়োপ্যাথি ডেফিনিশন দেওয়াটা কঠিন, মানে আমি মনে করি আর কি।
Then another question: is there any superiority of ACE inhibitor one upon another for using in case of heart failure or ischemic cardiomyopathy or dilated cardiomyopathy or idiopathic cardiomyopathy or postpartum cardiomyopathy? Superiority of ACE inhibitor and beta blocker also?
It's a good question.
Is there any superiority?
Definitely, a lot of study has shown that is the ACE inhibitor, especially ramipril and enalapril. There are a lot of trials has done by the enalapril, but ramipril also is very good drug now. And in cardiomyopathy, that is carbidelol. Sorry, telephone. Carbidelol is one of the best beta blocker for the patients. We can also use other third generation of beta blocker also.
Say metoprolol, carbidopa, and bisoprolol. Which would you prefer in your daily practice? Carbidopa, metoprolol, or bisoprolol? Which one?
It depends on the patient's condition. When the ejection fraction is very low, we are using carbidopa if patient can tolerate it, because metoprolol sometimes ejection fraction is relatively good. Patient can tolerate, and metoprolol is one of the best drug in this sense. It controls the heart rate.
Sir, can I add something?
এখানে একটা ব্যাপার আছে, one thing regarding the use of ACE inhibitor. It is very important question. Is there any ACE inhibitor has any superiority over other regarding the control? Actually, most of the initial investigation on heart failure was done first with captopril, with enalapril, and then acipril. So most of the initial investigations were done on these three drugs with excellent result. Later on, when ramipril came with HOPE study, it gave a extra thought that it might be better than other ACE inhibitor. Then came perindopril. Perindopril also showed a very excellent result. So in my opinion, all the ACE inhibitors are as good as others. Nothing to choose one over other. If patient can afford, you can go for a costly one. If patient cannot afford, you can simply go for it. Even captopril is well enough if you can give the highest possible dose. The most important thing in using ACE inhibitor is titrating to the highest possible dose. That's more important, not the class of the patient. How much the dose you can titrate to the highest level. That is the beneficial level. You know, one study that has shown that the benefit shown by ACE inhibitor was triple the dose we are using. So whether our dose of ACE inhibitor either benefiting the patient at all or not is doubtful, because the dose in captopril which showed benefit was 150 milligram per day, enalapril was 20 milligram per day, and acipril was 20 milligram per day. So we are not using this much dose nowhere. So I think any ACE inhibitor is as good. And regarding beta blocker, I think it's a competition between metoprolol and carbidopa. Both are as good, but carbidopa has a wedge over in patient with very low ejection fraction. You can start very low dose, but I think metoprolol and carbidopa has both almost similar control heart failure. Thank you.
Professor Bodhizaman, one comment. You know, one thing is that for examination purpose, also I think the student should say we should titrate the dose to the maximum that that patient can tolerate. You know, this is something very important, that different patients tolerate doses very differently. And for someone, it might be very difficult. And I have personally seen that Bangladeshis tend to tolerate hypertension very poorly.
Very poorly, very poorly.
But, ma'am, one thing very important for any antihypertensive is half-life of the drug. Captopril is a very good drug, especially in hospitalized and acute decompensated failure. But when the patient is out of hospital, always ESC and our guideline, they always the recommendation is to use the longer acting, especially ramipril, perindopril, because captopril you have to go to, we have to give 3 times in a day. Enalapril even we have to give 2 times in a day. So perindopril and ramipril is convenient. The same is true for beta blocker. If the patient has got mainly failure symptom, hypertensive, then carvedilol is a very good drug, as Badrujaman sir told. But if the patient has got frequent PVC, chance of arrhythmia, chance of sudden cardiac death is higher, this patient should be better benefited with metoprolol. And bisoprolol, especially newer trial shows that it is equivalent to metoprolol regarding arrhythmia and heart failure. And regarding nebivolol, there is little or less study in heart failure regarding its mortality and morbidity benefit.
Regarding dose of the beta blocker, it is saying that it started very low doses first and gradually titrated up to the is maximum doses.
Maximum tolerated dose for that patient, for every.
But carvedilol, sir, it's in addition is an alpha blocker, yeah.
Yes.
And it has an anti.
Both beta and alpha.
Other effect, ancillary effect that has not got other beta blocker.
Yes,
Okay,
it
sir,
is
another question, sir. Another question. The role of revascularization, especially patient having low ejection fraction, 20, 25, 26, 30% ejection fraction, patient having LAD 99%. Should we revascularize before MPI, doing MPI, or directly revascularize?
It depends on patient's condition. এখানে বলা হয়েছে যদি patient who are very much with chest pain or something like that, patient needs condition of the patient whether he is capable or not for surgery. If patient যদি সার্জারির জন্য হয়ে থাকে তাইলে আগে দেখতে হবে যে পেশেন্টকে আমরা কি করতে পারি। তো সেক্ষেত্রে আমাদের যেটা মানে করা দরকার, যদি ইজেকশন 25-30 হয় সেক্ষেত্রে যদি পেশেন্ট টলারেট করতে পারে, ভায়াবল মায়োকার্ডিয়াম থাকে, তাকে আমরা সার্জারি করতে পারি। যদি সার্জারি করার অবস্থা না থাকে তাইলে তাকে আমরা পিসিআই করতে পারি। অ্যান্ড এখন পর্যন্ত এই তিনটার কম্বিনেশন খুঁজে পাওয়া মানে কোনো স্টাডি নাই, মানে সিএবিজি ভার্সেস PCI versus optimum medical management. These three, it is shown that CABG better than PCI, PCI better than medical management.
একটা প্রশ্ন শুধু হচ্ছে যে whether we should go for a revascularization
before.
No, মানে if there is no evidence of presence of viable myocardium or ischemia, is there any role of surgery? Surgery একটা রোল থাকতে পারে, যেটা বললো যে সাইজ মানে reduction of the size অথবা removal of the scar. These are the different aspect, not revascularization. There is also the remodeling of the heart. But regarding revascularization, if there is no definite evidence of ischemia, whether these procedures are going to help the patient or not, that is very strongly doubtful. So I think it has a strong doubt. So in patient with ejection fraction less than 30%, but having almost thinned out myocardium, I don't think revascularization is going to help in these cases.
One thing,
daily practice, ma'am.
Now, one thing I just feel is that, I mean, if the patient you suspect and there is indication that there is viable myocardium, if the patient is totally like it's fibrotic, akinetic, and it's like more than 70 millimeter, Professor Nazir Ahmad showed us what were the bad prognostic signs in ischemic cardiomyopathy. But if you have a patient that you suspect strongly and there is indication that that patient has viable myocardium, as Professor Nazir said, that patient has chest pain and all, and you want to do revascularization, and theoretically bypass is the best, okay, but there is this whole chapter now of CHIP, because complex high risk indicated PCI, because in the real world globally surgeons usually do not want to do surgery on patients who have very poor ejection fraction or who have multiple comorbidities. And usually these patients do have multiple comorbidities. Most of them are diabetic, many have chronic kidney disease or have COPD or are very elderly or have such heavily calcified vessels that they are not graftable. They're diffusely diseased. So I feel that CHIP, revascularization in CHIP procedures is something that needs to be considered actively.
Exactly, ma'am. That is very important. The difference between the PCI and surgery, CABG, in low ejection fraction, important thing is that complete revascularization. If the lesion is such that PCI can completely revascularize with single or 2 or 3 stents, I think outcome will be equal. Surgery is more superior because complete revascularization with multiple distal grafting, LAD, LCX, OM, diagonal, that's sometimes not feasible by PCI, make the difference.
Okay, let us see another some question for other speakers. Dr. Nazmul Laila, what is the role of bromocriptine to treating a postpartum cardiomyopathy? Is there any role upon lactation or anything else?
So bromocriptine, it counters the prolactin, the fragment of prolactin that causes microvascular injury, cardiac injury. So it improves the outcome of peripartum cardiomyopathy. And it's given in certain doses. In uncomplicated cases, it's given 25 milligrams once daily for a week. And in complicated cases where the ejection fraction is less than 25% or the patient has persistent cardiogenic shock, it is given in 25 milligrams BD dose for 2 weeks, followed by single dose for a further 6 weeks. So it counters the effect of the 14 kilodalton fragment of prolactin.
Okay, thank you very much. For Dr. Farhad. Dr. Farhad, do you hear me?
Yeah.
Dr. Farhad.
Farhad,
what is your opinion regarding the use of digoxin, especially patient having idiopathic cardiomyopathy, cachectic, ill cachectic? Do you recommend digoxin for these patients? In addition to other drugs?
Nowadays, it is not the initial choice, actually. If patient is in sinus rhythm.
Yes.
If the patient is in have atrial fibrillation, in that case, there is no other option, then we can choose this. But though it was the primary choice in initial part of in this form of cardiomyopathy.
Okay, any comment from our panelists and faculties, ma'am?
May I have some comment?
Sure.
Actually, if Farhad Jamal is rightly mentioned, if there is no atrial fibrillation, so role of digoxin is a very less. If we consider the trial, the heart failure trial, DIG trial, where the digoxin was used, they mentioned that digoxin doesn't improve the mortality. It's some sorts of increase the hospital admission or some like this, but it doesn't increase mortality or it doesn't increase the disease, it doesn't reduce the disease process. So digoxin is not a good choice for a heart failure unless there is an atrial fibrillation. Thank you.
But anyhow, Dr. Nuralam, that reduces the recurrent heart failure hospitalization rate, improve the symptom of the patient. And till now in the textbook also, they have written this is the when ACE inhibitor, beta blocker, nebivolol, and all other, even with all other therapy patient is still symptomatic with tachycardia, then digoxin at low dose has got role. At least symptomatic improvement and reduces the heart failure hospitalization rate.
But Dr.
Professor Sabina Hashim has a comment.
Bottom line,
Yes,
yeah.
sir.
Yeah, ma'am.
Professor Sabina Hashim wants to say.
As everybody mentioned, heart failure treatment first beta blocker, SC inhibitors, and then aldosterone antagonists. And third, if the still after that, if the heart rate is more than 70, ivabradine is preferred, then digoxin. So first comes ivabradine. So in the digoxin goes in the bottom of the list.
Yes, can I add something?
Yes, sir.
Yes.
Please come.
If the patient is in sinus rhythm, digoxin is contraindicated virtually, because digoxin has an effect on hyperpolarization of the left atrium and causes atrial fibrillation by its own. So if there is no atrial fibrillation, no digoxin. If the patient is in sinus rhythm, no digoxin. And I want to add something regarding the use of SC inhibitor. SC inhibitor preferably with given the tissue SC inhibitor. Two are the tissue SC inhibitor. One is ramipril and one is perindopril. Others are vascular SC inhibitor, because SC inhibitor, the tissue SC inhibitor inhibits the angiotensin converting engine inhibitor in all the tissues. So remodeling is good in case of perindopril and case of ramipril. So a preferable use of SC inhibitor is perindopril and ramipril.
Okay.
After just comment হচ্ছে যে there are a lot of treatment has mentioned. One is very important, very normal treatment is correction of anemia. Actually, it is a very vital part of treatment of all the cardiomyopathies so far mentioned. Even if the hemoglobin is above 10, if you do serum iron level, serum iron profile, you will see the iron level is very low. Even if the hemoglobin is all normal, correcting the serum iron by injecting intravenous iron will improve the symptom very fast. So I think in all the patient with heart failure, even if the hemoglobin is around 10 or 11, you should do an serum iron profile. And if iron level is low, I think correcting the iron level, I think improves a lot. And symptomatic improvement is very important. So I think it's a very important thing, though I think this is not very much discussed, but I think it's an important thing.
Injectable iron.
Yeah.
Injectable iron.
Injectable.
Madam, already 10 p.m.
Roll up.
Yes, it's already 10 p.m. So you need to conclude. I mean, it's a great discussion, but it's 10 p.m. and it's a winter night, right? And we have kept our guests too long. We're so grateful to Noor Alam and Sabina. They've been so patient with us. Thank you so much for coming. I'm so grateful that you both came. Really appreciate it. Thank you. So you need to conclude.
Madam, thank you for Incepta, for our scientific partners.
Yeah.
Having a wonderful evening for us with very good discussion with cardiomyopathy. Thank you very much. Thank you all.
And thank you to all our speakers and thank you to our guests. Thank you.
Thank you, madam. Thank you, sir.
Thank you.
Assalamu alaikum.
Alaikum salam.